This was a work as a collaborative effort of a couple of researchers that had a chance to work with the JAK inhibitor Momelotinib as well as JAK inhibitor fedratinib. And the whole idea was to compare safety results that basically are reported on these drugs in so far published studies and available data in more than 10% of patients. And basically what we did indirect matching adjusted analysis where the baseline characteristics of patients on Momelotinib studies, particularly including Simplify 1, Simplify 2, and Momentum, and then studies for fedratinib, particularly Jakarta 1 and Jakarta 2, divided for either JAK inhibitor naive or JAK inhibitor experienced patients. And then after a reweighted of characteristics and removing major imbalances, the odds ratio and risk ratio for safety of all reported adverse events that happen in more than 10% of patients were compared. And we are presenting this poster at this ASCO showing that JAK1, JAK2 CVR1 inhibitor Momelotinib actually showed superiority in key hematologic and gastrointestinal adverse events such as anemia of all grades, as well as anemia of grade 3 and 4, diarrhea, nausea, both all grade as well as grade 3 and 4, and treatment emergent adverse events that either led to therapy discontinuation or drug reductions. That was noticed in patients with JAK inhibitor experienced myelofibrosis. For patients with JAK inhibitor naive disease, actually we also noticed the same side effects favoring Momelotinib and also grade 3 and 4 of thrombocytopenia, and all grades of thrombocytopenia favored Momelotinib. We have not seen any adverse events that was less pronounced than fedratinib in both of these studies. Then there was also specific analysis done that basically accounted for data that were not either available or not completely reported, or in a different assessment of these treatment emergent adverse events, either on fedratinib or Momelotinib, and did analysis show exactly the same thing. So Momelotinib showed to be superior in terms of these major hematologic as well as gastrointestinal adverse events, as I've mentioned, anemias, thrombocytopenias, diarrhea, nausea, and those treatment emergent adverse events that are leading to treatment discontinuation or reduction of the dose. So in overall, with this adjusted indirect comparison analysis that of course has some limitations, we have already suggested that we have hopefully another safe and promising JAK inhibitor that could be used in patients with myelofibrosis that were either JAK inhibitor naive or JAK inhibitor experienced. We're hoping that we will have or we get an approval of Momelotinib in the next coming months by the FDA, which we don't know how the indication will look. However, based on the recent Momentum study that show better results of Momelotinib over danazol in patients with anemia, that might actually get quite in the indication. So we'll see what the real world is going to show. However, this really is showing as a potent JAK inhibitor that is very strong in terms of controlling symptoms and spleen. So it is not only an anemia drug, but through its unique action with the inhibiting ACVR1 and the work of hepcidin could also actually improve anemia. So we know that the currently approved JAK inhibitor, such as ruxolitinib, is a very potent JAK inhibitor. However, it does causes anemias and then thrombocytopenias, based on which actually we even dose the levels. So that could be concerning, especially in some older patients that would not tolerate this amount of transfusions or such a significant drop of blood levels. So that could be a really, really reasonable alternative. So I think that would really bring another potent and powerful JAK inhibition as a treatment armamentarium for our patients. I think the next step for us would be to explore whether we could actually combine it with something else. I think we all equally excited about seeing where the drug is going to be posed in the myelofibrosis field. And as mentioned, we all be looking forward into trying to combine it with something else, mostly because it's favorable non-cytopenic effect on these patients. Of course, we will have to learn how to pick and choose. So what JAK inhibitor, where we're going to have 4 almost certainly coming, are we going to be using in what patients? So the next decade is going to be finding the right JAK inhibitor for the right patient and monotherapy versus combination therapy. So we are quite excited about another drug that's coming to the field.